Good morning, good afternoon, good evening, everyone. My name is Bont, and I welcome you all on behalf of the ReSViNET Foundation. It's a pleasure to be here during the second webinar, and I'm very happy that you all found your way back to the ReSViNET webinar. Our mission from the ReSViNET Foundation is to connect global expertise and leadership in order to decrease the global burden of RSV infection. And as you know, our mission is to support performance of high-quality research to improve knowledge of RSV epidemiology and to develop safe and effective therapeutic and preventive interventions, with the goal to advocate, create awareness for RSV, to act as a focal point for effective partnerships with all the stakeholders, and to combine knowledge and capacity required to enhance development of novel RSV therapeutics. So why are we here? Why do we need research and education? 33 million patients, 3 million hospitalizations, and 120,000 in-hospital deaths only, most of whom die before the age of 5 months, and virtually all in low and middle income countries. That's why we're here today. The objective of the webinar series by ReSViNET is basically to promote knowledge sharing of latest developments and to provide education to all professionals, also the young professionals in the field. Every 2 months, we will discuss a recent high-level publication, and today we will learn the lessons from the Novavax phase 3 maternal vaccine trial with the speaker Shabir Madhi, who will be introduced later on. With my co-host Jessie Groothuis. She has a Dutch name, Dutch ancestors, but she's all American, and I'm very, very honored and pleased and proud that we can co-host this meeting together. She is really the mother of RSV research, and she was at the basis of the development of passive immunization against RSV that has prevented so much RSV disease in the world. Before I give the floor to Jessie to take over, I would like you to know that on January 27th, Peter Openshaw will speak about his recent science paper a few weeks ago on the role of neutrophils as a mechanism of severe RSV infection using his human challenge model. Jessie, the floor is yours.
Everyone who is at this presentation, I think it's very exciting. Those of us in the field have, for a very long time, hoped for some way to actively or improve the passive immunization of healthy, seemingly healthy newborn babies less than 6 months. So it is my pleasure to introduce Dr. Shabir Madhi. He is professor of vaccinology at the University of Witwatersrand. He's the director of MRC Vaccines and Infectious Disease Analytics. And he is also the co-director of African Leadership in Vaccinology Expertise. Dr. Madhi, you have the floor.
Thank you, Jessie, and thank you, Louis, for this invite. So it's a real pleasure for me to be speaking to you about RSV today. I think most of us over the past 9 months have been very much consumed with COVID-19, and many might have actually forgotten that there are actually other viruses around, including some that have been with us since the 1960s, which, as Louis pointed out, still has significant impact in terms of childhood morbidity and mortality. So what I'm going to do over the next 25 minutes is really share with you some data which was recently presented at ASPID in relation to a post-hoc analysis of a phase 3 efficacy trial, which many of you might have seen about 2 to 3 months ago, that eventually was published in the New England Journal of Medicine, which reported on the first study to actually, in my mind at least, show that RSV is preventable through vaccination. Lewis, can you go to the next slide? My icon seems to be stuck. The next slide, please. Okay, so as Lewis pointed out, each year, roughly about 50% of all children that die because of RSV and of all of the hospitalizations which occur in low middle income countries. And it's only, I think, over the past few years that we see that prevention of RSV, especially in young infants, is becoming very much a reality, either because through maternal vaccination as a possible route, or because of monoclonal antibodies, and especially the new generation of monoclonal antibodies, which have got a long-lasting half-life. So just to emphasize the huge impact that RSV has got in terms of hospitalization in low middle-income countries, these are data that were published from the PERCH study, a multi-centered study undertaken across African and South Asian countries, which in the 1 to 5 month age group indicated RSV was responsible for close on to 46% of all hospitalizations. And across all of the countries that participated in the study, RSV was the dominant cause of hospitalization, and this is severe or very severe pneumonia hospitalization, and that ranged from 20% to above 50% in some of the different sites. Next slide, please. So the data that I'm going to share with you is based on this efficacy trial, and this was a multi-center study involving multiple countries as well as multiple sites within each of those countries. As I mentioned, the main objective of the study was to evaluate the efficacy of a nanoparticle F protein vaccine that was adjuvanted to matrix F. And pregnant women were vaccinated during the latter part of pregnancy, between 28 and 36 weeks of gestational age. Overall, the study actually stopped because of an interim analysis that was done after they had enrolled about 4,600 pregnant women. These pregnant women were followed through to 6 months postpartum, and after the babies were born, the babies were followed up through to 12 months of age. During the first 6 months, especially during the RSV season, there was active surveillance that was undertaken, which involved weekly contacts with the parents to determine whether the child had any signs or symptoms suggestive of a lower respiratory tract infection, and if so, they were brought into facilities to be investigated. In addition to which, at any point, if the child presented with an illness, a respiratory illness, without it being solicited for them to come in, so these were unscheduled visits, the child would also have been investigated for RSV. Next slide. So this has the top level results, and like I mentioned, these data were published recently, and this is for the overall study cohort. In the protocol analysis, looking at different endpoints, the main primary endpoint of the study was medically significant LRTI. You can read the definitions at the bottom of the slide. And the study was basically showing roughly about 40% efficacy. Looking at a 97.5% confidence interval, the lower bound was -1. And unfortunately, because of that, it actually missed its primary endpoint, which was required for licensure by the regulatory authority. The agreed endpoint was for a lower bound of the 97.5 confidence interval to be above 30, and as you can see, that was sitting at -1. So it missed its endpoint. It missed the predetermined endpoint for licensure with the FDA. Looking at other endpoints with a spectrum of more severe disease, as we move to the right, there was a 44% reduction. There was a 44% reduction in LRTI hospitalization due to RSV, and a 48% reduction point estimate for LRTI with severe hypoxemia. Now, the protocol analysis was limited to those individuals, those children that presented to the study site, that were investigated study staff, that were evaluated by study staff, and that had a sample that was processed by the central laboratory. Now, as you can imagine, when it comes to seeking care for children, many children might not present to the study site directly, and they might end up going to another facility where they would be attended for. So those endpoint cases weren't included in the protocol analysis, But in a secondary analysis, which I would refer to as an expanded intent to treat analysis, we now included all of the different endpoint cases. So as you can see, the number of 35 in the primary analysis increases to 56 in the expanded intent to treat analysis. When we increase the number of endpoint cases, what we find is that the vaccine efficacy remains fairly stable compared to the protocol analysis, with a 41% reduction in medically significant LRTI, a 42% reduction in LRTI hospitalization, and a 60% reduction in RSV LRTI with severe hypoxemia, with the lower bounds above 15%. In addition to the RSV LRTI endpoint, what we also examined was the efficacy of the vaccine against all-cause pneumonia. And as you can see, the efficacy for medically significant LRTI, irrespective of etiology, was about 22%, 36% for all-cause LRTI hospitalization, and an efficacy of 47% for LRTI with severe hypoxemia. Next slide, please. So what I'm going to present and focus on now is the findings from South Africa, which was a post-hoc analysis. And we were fortunate in South Africa in that more than 50% of the participants were actually enrolled across 7 sites in South Africa. And because this is really a post-hoc analysis, I'm going to mainly focus the discussion around expanded intent to treat analysis. The reason for that is that it's more all-encompassing in terms of the true burden of disease that was experienced in this particular cohort, and is probably more generalizable to the real-world experience with this particular study. So when we're looking at extended intent to treat analysis, we're looking at all endpoint cases that occurred at least 14 days after the mother was vaccinated. So from the time the child needed to be born, at least 14 days from the time of maternal vaccination, and all endpoint cases would be included. Inadvertently, because of a higher than expected attack rate in South Africa of medically significant LRTI, as well as most of the other endpoints, coupled with a large number of participants that were enrolled, we had more than 80% power to evaluate for vaccine efficacy of at least above 50%, with a lower bound of greater than 0%. So there was adequate power to do this post-hoc analysis in South Africa. Next slide. So what we found in South Africa is that, and what you see at the bottom in gray is the overall vaccine efficacy that includes children that were enrolled in South Africa. But for the vaccine efficacy estimate specific to South Africa, we see a 56% reduction in medically significant LRTI with a lower bound of greater than 30%. We see a 74% reduction in RSV associated with severe hypoxemia, and a 62% reduction in RSV LRTI hospitalization. So paradoxically, had the study only been done in South Africa, and had the study been allowed to use an expanded intent to treat analysis, it actually would have met the milestone that was set by the FDA in terms of licensure of this vaccine. As I mentioned, the criteria for licensure was a lower bound of the 97.5% confidence interval to be above 30%. In this particular instance, the lower bound of the 95% confidence interval was above 33%. For RSV-associated medically significant LRTI. Next slide. So what I'm showing here now is vaccine efficacy right through to 180 days of age. And I think this is especially important, and it's got implications for other studies around maternal vaccination. Because ideally what we're wanting to do is expand vaccination at least right through to 4 to 5 months of age, rather than the first 90 days of age. And what I've just presented to you as data up to 90 days of age. What we see in this particular analysis is that in fact the vaccine efficacy, and those are the estimates that are shown in the bars, was basically 45% through to 180 days of age for medically significant LRTI, 55% for RSV LRTI hospitalization, and 70% for RSV LRTI with severe hypoxemia. Not very different from what was actually observed through to 90 days of age. Now, the other figure that I'm showing you right at the top of this bar is what is known as the number needed to vaccinate. So these are the number of women that are needing to be vaccinated to prevent a single case of that particular endpoint. So as an example, for RSV LRTI hospitalization, 30 women would need to be vaccinated to prevent a single endpoint, and for RSV with severe hypoxemia, about 40 women would need to be vaccinated to prevent a single case of RSV LRTI hospitalization with severe hypoxemia. And I think this number needed to vaccinate is especially important in terms of being able to quantify the potential public health benefit of the vaccine, and also when looking at different vaccines in terms of vaccine efficiency, which I'll speak to right at the end of the presentation. Next slide. So one of the caveats with this particular analysis of looking through to 180 days of age is, unfortunately, the design of the study was such that we aimed to vaccinate women such that the timing of the birth of the child should occur as early as possible at the start of the RSV season. So inadvertently, what happens in a place such as South Africa, where the RSV season lasts for 2 to 3 months, is that children that are born just before the RSV season or just immediately after the RSV season, they're going to have very limited exposure to RSV between 3 to 6 months of age, because the epidemic usually lasts for about 8 to 12 weeks. Despite that, what we see is a few additional cases that are observed between 90 and 180 days. So by 90 days, as an example, in a placebo group, for medically significant LRTI, you got 44 cases, and you add another 5 cases when you follow them up through to 6 months of age. That doesn't mean there's only that the majority of disease is occurring up to 90 days of age. It's just an artifact of the design of the study that doesn't enable you to capture whether there is actual vaccine efficacy between a 90 to 180 day period. So what we're looking here is a study which is really biased in terms of the manner in which the children are enrolled, to basically only look at vaccine efficacy during the first 90 days of age. If studies are wanting to look at efficacy between 90 and 180 days of age, what they would rather need to do is be much more expensive in terms of when they allow women to enroll into the study, so that by the start of the RSV season, we've got some children that are already at 90 days of age, so we can look at vaccine efficacy between 90 and 180 days of age. Next slide. So in addition to looking at RSV LRTI, these are data which look at all LRTI hospitalization. And for me, this is really a stunning result. In that when you look at efficacy against all-cause LRTI hospitalization, we find at 180 days of age, a 31% reduction in medically significant LRTI, but the striking 60% reduction in RSV LRTI with severe hypoxemia. This is all-cause LRTI hospitalization. For LRTI hospitalization itself, we've got a 44% reduction, which is almost an identical estimate to what I showed to you in the initial slide in terms of the Perch estimate as to the role of RSV in terms of the etiology of severe and very severe pneumonia. Next slide. Now, when comparing this all-cause and RSV-specific endpoints, what I'm really trying to illustrate here is that although there's overlap of the 95% confidence intervals in terms of vaccine efficacy, so consequently, there would also be overlaps in terms of the 95% confidence intervals for the number needed to vaccinate. The most important thing and interesting thing here is that there is some sort of divergence between the number needed to vaccinate to prevent RSV endpoints and the number needed to vaccinate to prevent all-cause LRTI endpoints, with fewer women needing to be vaccinated to prevent all-cause LRTI endpoints than RSV-specific endpoints. So what does it tell us? Well, some of the children might not have been investigated for RSV, consequently the difference between the two. But another possibility is that some of these cases of LRTI that are being prevented are a consequence of RSV, but not because of RSV being responsible for that case at that point in time. And again, something that I'll speak to a bit later when I share with you some of our experiences with another vaccine targeted at pregnant women. Next slide. Now, the quick question that faces us obviously is, how long does this vaccine work, and do we understand what actually probably contributes to the efficacy of the vaccine? So this is immunogenicity data, and I think most people in the field do believe that neutralizing antibody is important in terms of protecting against RSV LRTI. But at the same time, no one has really been able to establish a threshold that is associated with protection. What we find is that following vaccination, there was about a 2.5-fold increase in neutralizing antibody to RSV-A and about a 4-fold increase of neutralizing antibody to RSV-B, 14 days after vaccination of pregnant women. At the time of delivery of the babies, those antibody concentrations were still significantly higher in the vaccinated women compared to in the placebo recipients, and much higher than compared to baseline. What we see is that the transplacental efficiency of transfer of this antibody was about 0.83 for RSV-A neutralizing antibody and 0.91 for RSV-B neutralizing antibody. Now, this transplacental ratio that I'm showing you for South Africa, in fact, is quite low compared to what is observed in many natural epidemiology studies from high-income countries, where that ratio is around about 1.2, 1.3. So there is actually some sort of attenuation in terms of transplacental transfer of antibody in South African children, and this is something that we've seen in other natural epidemiology studies as well in South Africa. Next slide. So what do we see in terms of the waning of the antibody? The half-life of this antibody is as expected, about 28 to 30 days. But what we see is that by roughly about 35 days, and the number of samples that were included here was relatively few. So that's the reason for the wide confidence intervals. But what we see is that by day 35 already, there's some overlap of the confidence intervals. And by day 90, in fact, there's much more overlap of the confidence intervals of the neutralizing antibody in infant serum. Now, based on this data, one would expect that this vaccine shouldn't be able to protect. If neutralizing antibodies is the key factor in terms of protecting against RSV with this particular vaccine, one would suggest that by about 2 months of age, you shouldn't have much protection, because we're finding that there's sort of this overlap of neutralizing antibody. And certainly by 120 days of age, there's almost no difference between infants that were born to vaccinated mothers and to the placebo recipients in terms of neutralizing antibody. So I think the short message here is that we still don't really know exactly what role neutralizing antibody plays in terms of protecting against RSV LRTI, at least in this context. Next slide. So the other thing that was also measured in this particular study was anti-F IgG ELISA. Now, I'm not saying that this by any means has got any relevance in terms of whether it actually protects against RSV, but it was a measure in terms of the immunogenicity of the vaccine. And as you can see, we see much more robust anti-F IgG ELISA antibody responses than we saw for neutralizing antibody. And much of that antibody is still persistent at the time of delivery, which was about 15 times higher than at the time of initial vaccination in the pregnant woman. And that antibody in this pregnant woman actually continues being 10-fold higher, about 9-fold higher at 6 months postpartum compared to at the time of randomization or vaccination of the pregnant woman in the vaccinated group. Next slide. Now, when we look at the kinetics of this antibody in infants of vaccinated mothers and of those infants born to placebo recipients, we find that this increase in antibody, the higher antibody concentrations, and I'm talking of the anti-F IgG antibody concentrations, persists right through to about 112, 120 days of age. By 180 days of age, this anti-F IgG is similar between the vaccinated and unvaccinated, and infants born to unvaccinated mothers. But we still see some sort of differences right to 120 days of age. The half-life of this antibody in the vaccinated infants was roughly about 37 days. Next slide. Now, one of the issues that was raised, and it was discussed in the supplement of the main paper, which is up to 72 pages, and I'm sure many of you probably haven't even managed to open that supplement right now, is this whole notion that perhaps what happened in South Africa is that more babies were born 30 days after the mother was vaccinated. And that might have allowed for greater transplacental transfer of antibody. And what we see in this sort of analysis is that indeed, children that were born more than 30 days after the mother were vaccinated, the ratio of antibody that was transferred to the child was much higher than the ratio of antibody that was transferred to the child for those that were born between 14 to 30 days. So we're wanting mothers to be vaccinated as early as possible, and ideally to be born at least 30 days after maternal vaccination, to try to optimize the amount of antibody that's actually transferred across to the baby. For this analysis, unfortunately, I'm only able to show you anti-F IgG responses, because we didn't have sufficient number of babies that had the neutralizing antibody done. Next slide. Now, one needs to be careful how you interpret this data. So what I've done now is I've basically stratified analysis to greater than 30 days and efficacy readouts for babies that were born between 14 to 30 days after maternal vaccination. And as you can see, for those above 30 days, those vaccine efficacy estimates I'm showing you through to
I hope you can all hear me. It's Louis here. This is not what we expected. Shabir informed us that he had a hurricane or a storm expecting in Joburg. I don't know whether that has just arrived at his place. I apologize. This is not what you expect on your second webinar. So I hope you all bear with me. My suggestion is that you all take a mini break. We just wait 2 or 3 minutes for Shabir to come back. We have plenty of time, so please don't close the webinar, and we'll be back soon. I'll switch off I'll close off for just a second. Hi everyone, I hope you can hear me. We're trying to contact Shabir. He has informed us that he has an internet cut completely, so he's now trying to join us by cell phone. We hope that works, but if not, I think we should move forward. I had only very shortly had the chance to preview the presentation, but I think it is. I think it's better to move forward. So I'll try to take over, which is obviously almost impossible for me. So I think Shabir has informed us that the children who were born less than 50 days after a maternal vaccination were had lower antibody titers than those who were born later, and I think this is something we have to take into account when we try to interpret the data. And here again, you can see that the effects, the impact of the vaccine is different for those who were born with or within 30 or beyond 30 days after vaccination. So one of the questions that are essential that is bugging us is, why is the vaccine working differently in South Africa from high-income countries? And this is an analysis that I'm not sure is part of the original publication, where you can see that there are that if we compare maternal age is more or less the same. If we compare racial differences, obviously there's a huge difference between the black versus the white community taking part. If we look at those who are primigravida, there is a little bit more in South Africa. The gestational age, this might be important, is lower in South Africa. So those women were vaccinated earlier in the course of their pregnancy. And as you can see here, there is an interval from vaccination to delivery within 14 days, beyond 14 days, 14 days to 30 days, and beyond 30 days. And you can see that there are some differences here between both groups. With most of the women in South Africa being vaccinated at least 30 days before delivery. The infants that participated, I think, may be of relevance as well, but you don't see a huge baseline difference or differences between children born to mothers in high income versus South Africa. So again, if the intention to treat vaccine efficacy in South Africa versus high income countries, you can see that the vaccine efficacy in South Africa is substantial versus below zero or actually not non-measurable in high income countries. So this still is a vaccine problem that may be related to timing of vaccination and in relation to delivery. Here we see the maternal participants, high income countries again versus South Africa. And when we look at geometric means of, then we see here that there are no major differences between the participants. So it's not clearly related, if I understand these data correctly. I wish Shabir was here, that the antibody titers are not clearly explaining why we see such a huge differential effect between South Africa and high income countries. So now Shabir wants us to understand how what the attributable fraction is of various respiratory pathogens. And I think you can see this much better than I can here from my presenting position. But if we look here at the fraction that is explained by each of these pathogens per site, this may be perch data. This is perch data. Then you can actually see that RSV, the attributable fraction of pneumonia, severe or very severe pneumonia by RSV is much higher than for flu or pertussis, suggesting that the RSV, again, is a major disease to combat. So then Shabir is going to translate his findings to influenza data that he has published in the past. And I think it's best that we leave this out because I find it very difficult to make this translation without him, because I don't know exactly the storyline that he had prepared for this part of the presentation. So I'll stop here for a second. Maybe I can move to the last slide before we open the discussion. And Jessie, please be prepared, because you have time to read the questions and we can just discuss them together. I think we all know the paper by Shabir quite well. There is a postdoc analysis that we have seen today with a full focus on South Africa, where more than 2,000 out of the 2,422 children were born versus less than 2,000 in the rest of the world. That showed that maternal RSV immunization protect infants against RSV infection through 6 months of age in South Africa versus nil in high-income countries. Vaccine efficacy ranged from 55% for medically attended significant lower respiratory tract infection to 70% for RSV with severe hypoxemia through the age of 6 months. Furthermore, 31% reduction in all-cause medically significant and 44% lower risk of all-cause LRTI leading to hospitalization, and 59% efficacy against LRTI with severe hypoxemia through the age of 6 months. So this really shows that RSV has a major part, or the attributable fraction of pneumonia to RSV is really high, because what you see here is that most of the effect is in the pneumonia. Notably, only 25, 28, and 32 women need to be vaccinated to prevent a single episode of all-cause LRTI hospitalization with severe hypoxemia, respectively, which means that the public health impact of such a vaccine in South Africa, should all these post-hoc data be confirmed in a well-designed trial, would be the public health impact would be huge. Shabir has now, I just see Shabir coming back. So I think for the sake of the discussion, wait 1 second, I'm going to show Shabir's face again, much prettier than mine. Right. So Shabir, I have tried to present your data. I think the message was quite clear. The only thing I left out was the comparison or the analogy with the flu data. I left them out completely because I wasn't sure about the storyline. And there is lots of questions. And I think these discussion points that you have raised here were really well discussed during your presentation and me wrapping up, including the attributable fraction of RSV to pneumonia. Is it okay that we start the discussion with the Q&A, Shabir?
Sure, yeah. My apologies for what happened.
No, you couldn't help that, so don't worry at all. Jessie, the floor is yours.
Okay, so there are several questions about the breast milk derived antibodies from a number of participants. The question is, can you perceive any breast milk antibodies were you able to show whether the antibodies came from the breast milk versus the placenta? That seems to be a very important question for a lot of people.
Yeah, so unfortunately, we didn't measure breast milk antibody in this particular study. I know Natalie Mazuru worked with Lewis, did do another natural happy study looking at breast milk antibody. But in this particular study, we didn't.
Can you speak a little bit closer to the microphone, Shabir? A little bit closer to the microphone.
I said in this particular study, unfortunately, we didn't analyze for breast milk antibody.
So what are your thoughts? How are they relevant for vaccine-induced protection to the infants, or is it more distant from the real impact?
Yeah, so I mean, I would be surprised that breast milk antibody would play such a substantial role in terms of protecting against RSV, LFTI. I think you need antibody, yes, at a mucosal surface, but the amount of antibody that you're going to get from breast milk is unlikely to explain the findings in South Africa, more so because it's very, very uncommon, in fact. 70% of women do not exclusively breastfeed in South Africa. So the number of women that exclusively breastfeed in South Africa is fairly modest. So it certainly wouldn't explain the type of efficacy that we're observing if breast milk antibody was a major modality in terms of protecting against RSV because of vaccination.
And it's my understanding, Louis, please correct me if I am wrong, that there has been some earlier studies on whether the antibodies actually pass into the breast milk, and it's my understanding that they really don't, to a degree that would be protective.
I think we agree.
Correct, and I think, yeah.
So while Jessie picks out another question, Shabir, I saw that you mentioned a half-life of the antibodies in the vaccinees of about 30 days. In your publication, you mentioned a half-life, if I remember correctly, of close to 50 days. Can you explain that?
No, I don't think that was half-life in the publication. The half-life in the publication was around about 30 days as well. There is something anomalous of babies that were born to placebo recipients, where for anti-IgG, you've got a half-life for as long as 220 days. But I think that's just a function of low antibody concentration taking a longer time to show decay than when we start with higher antibody concentration. But I think the publication itself, the half-life of the anti-IgG, as well as the half-life of the neutralizing antibody, was in a ballpark of about 30 days.
Martin asked a question here that actually I also was wondering about when you presented your data. He asks, why is there so much more time between vaccination and delivery in babies that receive it greater than 30 days versus as compared to, well, SA, he says, greater than 30 days, as compared to HIC. I'm not sure what he means here, 30 days. SA and HIC, I'm not sure what that means exactly.
High-income countries.
Oh, I'm sorry. South Africa and high-income countries, thank you. And why do you think there's such a difference?
So there wasn't, there was a difference in terms of the proportion of children that were born more than 30 days and between 14 and 30 days between South Africa and high-income countries. The main reason for that, unfortunately, is for unexplained reasons. Women tended to be enrolled at the later stage of pregnancy in the high-income countries. So I think the median gestation age at the time of vaccination, if you go to that, if you go to the high-income South Africa.
Sorry, where is it again? Let me see. Oh, we lost Shabir again. I apologize. Yeah, I thought it was striking. It's here where the question was coming from. Thanks. Good to see you again, Shabir. So the question was related to this slide, where the interval between vaccination and delivery is never more than 30 days in the high-income countries. So I think you are making the suggestion that this could be a key explanatory mechanism of absence of effect in high-income countries. Is that correct?
Yeah, so Louis, no. So the one thing I want to caution, if you just go to the next slide. So unfortunately, what I left out from here is the power of the study, this blank columns. And the bottom line is that you can't put any sort of value in terms of the vaccine efficacy readout from high-income countries. The power of the study to look at any of these endpoints based on the number of people enrolled was only about 40% in high-income countries. So what's supposed to happen on this slide is that there's a huge X across this high-income analysis, because it's completely incorrect to put any sort of value on any of those numbers, simply because in high-income countries, the study was not powered to do such an analysis. So for South Africa, we had adequate power to undertake this sort of analysis, but not in high-income countries. So for all intents and purposes, these are meaningless data from high-income countries.
So I have we lost Shamir, but I have a question. Maybe Louis can address it if Shamir doesn't come back. And I'm wondering, given the demographics of low-income areas, lots of crowding, et cetera, could natural RSV in the mother have, it doesn't look like that from the graphs, but I still wonder whether more mothers in the low-income countries actually had natural RSV, and whether that contributed to the difference between the low and high-income countries.
Shabir, any difference between low and high-income countries in maternal RSV infection? I can't hear you. No, I think we can't hear you, Shabir. Jessie, can you hear Shabir?
I cannot.
No, Shabir, we cannot hear you. Can you hear us?
I don't think he can. Oh.
Can you try again? Shabir, are you there?
Well, I guess it's a question that can't be answered, but it's a thought. There's another very good scientific question. Important to point out that the vaccine was, as far as I know, alum adjuvanted, not matrix M, which in retrospect is a pity because we have no data on matrix M in pregnant women currently given the SARS-CoV-2 vaccine.
So Shabir, can I ask you to switch off and on again, because we can't hear you? I can see that there's something wrong with the line. Can you just for a second switch off and on again? There is, I don't know, something wrong with the line. Any other questions, Jessie?
I don't see any other questions on my chat table.
So let me see.
Oh yes, here's one from Alexandra. Alexandra asks, I don't quite follow the difference between the per protocol and the EITT groups, and why the EITT group is more powered. Can you briefly re-explain this?
Okay, can you hear me now?
Excellent.
Wow, okay, so let's hope it works. So the difference between the per protocol and the EITT group is that the per protocol individuals needed to be evaluated at the site by study staff. They needed to have a pulse oximeter that was calibrated by the study staff, and they needed to be clinically assessed by the study staff. Some children would have ended up, as an example, hospitalized at the site where the study staff were not present, and all of the same investigations would have been done at the hospital, as an example. But they wouldn't have been, a sample wouldn't have been taken to a central laboratory, but rather the sample would have been sent to the site laboratory. So essentially what's happening is that there's endpoint cases that were missed simply because they weren't actually evaluated by the study staff. Whereas the EITT analysis includes all of those endpoint cases. So they fulfill the same sort of definition, but irrespective of who did the assessment or where the test was done, it's included in the EITT analysis.
So, Shabir, there is some pushback from the audience on your suggestion to prioritize 180 days in your primary endpoint analysis over 90 days. One of the reasons is that the antibody half-life and the decay that you have shown, or the development over time that you have shown, suggests that beyond age 90 days, little protection is expected. If you look at your own flu vaccine program and all the rest of the literature, to the best of my knowledge, maternal vaccines have never been shown to be efficacious beyond 90 days. So even though the post-hoc analysis suggests that, wouldn't you think that that could be an artifact and that it could be actually detrimental to have a primary endpoint until 180 days, because you could shoot yourself in the foot by prolonging until 180 days, even though we fully understood the challenge of vaccinating timely, because there is such a huge variation between vaccination and timing in relation to the RSV season. So you explained it very carefully, much better than I tried now. So what about 180 days again?
Yeah, look, I'm not convinced that this vaccine protects between 3 and 6 months. I'm certainly not convinced. And the study was not designed to assess that. And as you correctly pointed out, when we looked at maternal influenza vaccine, the vaccine efficacy up to 2 months was 84%. And then when we take it out to 6 months, it drops to 49%. And I think the same thing would happen with the RSV vaccine. So in fact, if you look at the slide closely, I didn't really focus on the 0 to 90 day age group, but the vaccine efficacy point estimates for 0 to 90 days, in fact, is marginally higher than 0 to 180 days. And all of the efficacy, as I pointed out, is really because of endpoint cases that are occurring up to 90 days. So I fully agree with that comment. The only reason I went up to 180 days, I think there might be another story to be told, especially for all-cause LRTI, including from natural epi studies, where we see that children that have RSV in the first few months of life, they have increased risk of developing a subsequent LRTI independent of RSV. And that is something that you can pick up as an all-cause LRTI analysis, but not a RSV-specific analysis.
So we're getting close to the end of the meeting. There is a question about, I think, correlate of protection. You show neutralizing antibodies in the cord blood, and you show outcome. So can you tell us whether this study has informed you what the correlate of protection should be in future trials? Should you do another trial with this vaccine or a trial with another maternal RSV vaccine? And if you don't, you're shaking your head. Why not?
Well, look, I think so. That analysis is yet to be done. So the number of samples that we analyzed for neutralizing antibody has been fairly limited up to now. But once that neutralizing antibody assays are complete, I think this study would be very well positioned. Firstly, to determine whether there is any association between neutralizing antibody and protection against RSV. That is the first issue. And if there is such an association, I think the study would be able to pick it up, because it's unlike COVID-19, where you've got a vaccine efficacy of 95%, it becomes almost impossible to develop a correlate of protection when you've got such high vaccine efficacy. You have enough breakthrough cases. Whereas with this study, where we've got a reasonable number of breakthrough cases, if there is that association with neutralizing antibody, then we would be able to pick it up. So hopefully that story will unfold in the course of the next few months.
I'd like to just make a comment here, kind of echoing what Louis says. The vaccine you use is a nanoparticle vaccine made by Novavax. There have been no studies showing how well this works. So my question there just aren't any studies that this type of vaccine, this nanoparticle vaccine, actually produces protection. So my question is, now that we know that, for example, the messenger RNA vaccines, the subunit vaccines, it may be a better vehicle to induce more antibody. And I first of all, I want to congratulate you on this huge study and how well you were able to, having done these types of huge studies myself, I know the effort that comes in. So this is not a criticism. This is more of a, can we learn from the rapid movement of these COVID vaccines to actually have a better vaccine that might actually be more protective, such as the messenger RNA vaccine? So
I unfortunately cannot let Shabir answer this editorial comment of our highly prestigious co-moderator because of time. Peter Openshaw, our next presenter in 2 months. I hope you have enjoyed this session. I hope you are not discouraged by the technical issues. We're learning. I apologize to everyone that this is something that can happen. I hope you enjoyed it still as much as I did. Thank you all for being here. The session will be available through the ReSViNET website for those of you who were not able to see it or want to show it to your colleagues. And I would like to give a huge online applause to you, Shabir, for staying with us and having the patience to work with us. So thank you very much. Enjoy the day wherever you are, and stay safe. Bye.
Thanks, and apologies.